Well, good afternoon or good morning, depending on when this video is being aired. Congratulations on making it to the 2024 Wellness Summit. I want to thank the organizers for asking me to participate. My name is Cassandra Price. I'm the director of the Office of Addictive Diseases within the Georgia Department of Behavioral Health and Developmental Disabilities, also known as DBHDD. I am also known as the State Director, SSA, for Substance Use, and the immediate past President and Policy Chair for NASDAD, the National Association of State Agency Directors. So I'm honored to be joining you today and contribute information as it relates to your theme, Health in Action. I will be focusing my presentation on the following, and we'll go over this as I begin. Opioid maintenance during pregnancy, statistics from SAMHSA, Substance Abuse Mental Health Services Administration, DBHDD's Women's Treatment and Recovery Support Services overview, the DBHDD-sponsored Motherhood Behind Bars pilot program, the WTRS Family Transitional Housing pilot, and the Maternal Peer Support Program, and 988 and GCAL resources. So that's just a introduction of what I will be covering today. And let me share my screen. So I wanted to take a moment, and here's the topics we're going to do as an overview, but I wanted to give you a little background about my journey in this field that I think kind of will all come full circle as we talk about the different things that are prominent at DBHDD and some of the federal things. But I am a recovery ally. My father is in long-term recovery from alcoholism. And I grew up in the halls of AA as a child, attending open meetings with my father. So I had a good sense of what recovery looked like from a family perspective. I graduated from University of Georgia, go Dogs, with a communications degree. When I graduated, I really wasn't sure where I wanted to land and what I wanted to do. All I knew was I needed a job. And so I went and applied for several different positions in the social services area and interviewed at a women's treatment program. And that was in Rome. I live in Rome, Georgia, not Rome, Italy, as you might guess by my dialect. And I went to this program, and it was a very low-paying job, to be honest, but I was interested because of some of my background, and I just wanted to interview at as many places and see what really seemed to fit. So I'm sitting in the waiting room, and there's a young lady on the couch, and we entered into a conversation. And some background about me: I am in a wheelchair due to a spinal injury over 34 years ago. I am I'm an extrovert, and apparently I'm one of those people that everyone talks about, have an openness, and that's not a bragging thing because it can sometimes be pretty overwhelming, but people do seem to feel they're curious and they're very open with me. So this young lady is on the couch, and she asked me what I was doing there. And I told her I was there for a job interview. And I asked her, what was she there for? And she told me crack cocaine. I mean, literally just kind of blatantly throwing that out there. I was like, okay. So we proceeded. They were running late with the interview. We started having a conversation, and I asked her, I said, is this program helping you? And she said, it is. And she told me a little bit about her history, that her mom was addicted, that she grew up very poor, and that there was some family abuse history, and that addiction was kind of a way of life. And she had two children that had been removed from her custody. And it was her hope that she would get those children back in this program because the children could come and live there and be reunited with the parent. And as we're talking, and I'm like, well, what's missing in your treatment, or what would you wish that was a little better? And she said, well, I haven't told anyone here, but I'm illiterate. I can't read, and I'm embarrassed. And there's a lot of books and a lot of things that I'm really not participating in the way that I should because of this issue. And she didn't even use the term illiterate. She said, I can't read. And so I'm paraphrasing there, but that moment really, really touched me. And so I went back for my interview, and I even shared that with them that I met someone, and I kind of got a feeling that this was where I needed to be. They kind of pretty much hired me on the spot because I had a degree and a pulse. As you guys probably can guess, in the behavioral health field, especially in the addiction field, there is a huge workforce shortage. And so I was hired as an incoming counselor. This young lady was actually on my caseload. We were able to get her some literacy reading classes, and she became literate and could read and could participate in the workbooks. She graduated from that program, stayed in the outpatient program for a very long time. She regained custody of her children. The last time I saw her, I think was 3 years ago, and she was still in Rome with her children, working at the hospital in their hospitality section. And so I tell that story just to connect kind of how I ended up in this field from a very early standpoint. And then just when I talk about the women's treatment that you see, my passion for it is very great because that's where I started my career. And I also like to start out with a story of hope. As we look at really bad statistics and we talk about the problem, we always want to start with recovery and maybe end with recovery. I think that's important. From there, the women's program, I became a certified addiction counselor. Later on, I got an MBA in business. And then I was recruited to come work at the state office to be over all the women's programs. And then in a few short years, I was actually became the state director. So that's just the quick path of my career that I just share, really not as any kind of bragging rights, but just to connect my passion for the field. So now here's the topics we're going to recover. I mean, we're going to cover. You see, I just can't stop talking about recovery. So let's jump into opioid misuse during pregnancy. So, the past decade, we'll see, a ton of changes in drugs and what's become abused more in the system or in states. And so I want to be real transparent that the data that I'm sharing with you guys today is a little dated. I had to put this presentation together quickly, and I had to pull data sets that were complete and had some visual aids. And so this is some 2000, 2009, and then 2012 data. On the SAMHSA website, there are more current TEDS data. That's the data sets that I look at. But again, they didn't have the visual representation or even kind of the completeness that I was looking for to paint a picture. You will see there's a few changes here and there, but some of the data stays pretty statistically relevant, not a ton of changes. But I just wanted to be transparent there. So you see from 2000 to 2009, from 1.19 to 5.63% of 1,000 hospital births per year, there was an increase around opioid use. And so what we know is that comes in tandem with neonatal abstinence syndrome among newborns, with the withdrawal symptom caused by that maternal opioid use. And so we know that dependence during pregnancy is associated with low birth weights, respiratory complications, and of course, born with that dependency that has to be dealt with after birth. And you'll see that 70 to 95% of those newborns of NAS are born opioid dependent from opioid dependent women. The standard treatment for opioid use disorder pregnancy is methadone and buprenorphine maintenance therapy. Of course, that can also result in NAS, but it should be noted that when that is in a controlled clinical environment, and that is in a treatment process that is wrapped around the mother, that the NAS complications are much less, and the baby or infant is able to be titrated down quicker in a more controlled way versus someone who is using opioids or heroin or other things in a different frequency, different amounts, different types. Maintenance therapy, of course, is the steady concentration of opioids in the pregnant woman's blood, preventing the fetus from experiencing cycles of toxicity and withdrawal. And then, we also would expect there to be prenatal care and services wrapped around a woman who is getting that therapy while pregnant. So here's just some quick stats again, 2007, 2012. Pregnant and non-pregnant past opioid misuse in women 15 to 44. So you see the pregnant is the green. Even in comparison to non-pregnant, you see it's a pretty significant amount of prevalence there of women that are using that are when they're pregnant of opioids. The next slide is the past month of 15 to 44 and the poverty level. We know poverty level is a significant factor, but not always in the opioid space. We know that is affecting lots of different people and groups. Next, reported misuse ages 15 to 44. And here, this is admissions. And so you see 22.9 with heroin, pregnant women. And I've got some data here too in 2012 of the 428,662 female admissions, about 5.0%, 21,553 were pregnant admissions. And then I looked up the data for 2020, and 3.9% of treatment admissions nationally were women who were pregnant. So we saw that kind of decrease, but there were 4 or 5 states that didn't report. So we might make the conclusion that that number is probably a little bit higher because we have some missing state data. But I just kind of give you that to kind of give you some reference of the data set from there to now. And then we have the health insurance, which is important because you've got a lot of women covered by Medicaid, which is great. And then you've got 32.7 that have no insurance, which then indicates what? They haven't had any prenatal care, more than likely. And so getting them into treatment and wrapped around with prenatal care is very, very important to ensure the health of the infant and the mother during the term of pregnancy. So next, how is Georgia addressing this problem? So I'm going to talk about our Women's Treatment Recovery Support Services. We call those WTRS for short. We also have a sponsored Motherhood Behind Bars pilot program, WTRS Family Housing Pilot, and a maternal peer support program. So we're going to talk about those programs that help support women with dependent children, and especially pregnant women. So our Women's Treatment and Recovery Support Services is called WTRS. It's gender specific, has a full continuum of care, a priority admission for pregnant women and IV using women, therapeutic child care for children 13 and under, and they're permitted to live on site with a mom. The work is to reunify the child with the mother if they are in foster care. We have a strong partnership with DFACS, who actually helps fund a part of these beds. We have 486 residential beds. We have a focus on trauma, addiction, and promote recovery through clinical and peer support services. And if you're not familiar with peer support in our field, it's a certified peer specialist. And those are individuals who have lived experience in the realm of substance use disorder and or mental health. And they are individuals who are able to provide a peer support service based on their lived experience and help an individual or a woman through the treatment process, understanding defects, understanding a lot of things that happen, and being able to use their lived experience to support an individual. 100% of infants that were born in WTRS are healthy and illicit substance free. 90% successful completion rate of women in these programs, and they gain employment skills, and 92% become gainfully employed while in care. So those are some outcomes. So we do promote job search and support them to become employed and work on their employment skills and resumes and all those things is a part of the residential program that can be up to 6 months. It just depends on the individual. So they're individually based as far as the length of stay. Next, we have the Motherhood Behind Bars pilot program, started relatively new. And so we have use of peer supports that I mentioned, ensures that we have infants that are born to incarcerated women by providing comprehensive support, long-term healthy reunification, and permanent into the cycle of reincarceration. They do gender responsive reentry services. So trying to really help a mother that is leaving jail to be re-entered into society in a way that's healthy, and that they can help reunification occur by linking that mother to treatment. It's one of the first of a kind of United States. And it's been launched in Fulton County Jail, successful integration with a perinatal health education and harm reduction strategies, diversion being the primary goal. So that's some work we're doing with a provider. And then we have the transitional housing pilot. We're using some of our supplemental funds from SAMHSA to support this. It's a year in a transitional, includes both parents and children. So really kind of doing a family model. We have 10 housing units. We've had over 22 families served here in this program, and that includes treatment, employment services, peer support, psychoeducation, family counseling, and individual care. And we hope that we'll be able to continue some of this when the grant funds run out, because we think being able to support families is just really important. Here's a success story. I won't, read all of this, but you can see that this individual, this family had lost custody, and they entered this program, and at first was very distrustful and struggled, but they approved her to have visitation, and then the child moved in with them. They've completed comparative courses, and then successfully discharged after 10 months. And both parents are thriving in recovery as a family. So we'd like to be able to talk about when we have success stories and the individual that's to share that with the public. So next we have maternal peer support program. And so it's about having peer support for defects involved women. And when this happens at kind of a NICU or happens early on in the defects process, that we're helping infants with NAS, helping that parent feel supported. And so we have had over 1,000 encounters and follow-up encounters. We connect them to a treatment provider, support and accountability course, and resources for mothers and children. And so the Northwest Georgia Community Connections Project, those peers are working in the hospital to help those ladies who may have lost custody, and navigate that world and support them through a process. And these are even working with the nurses and the nursing staff who are super supportive in that clinical setting of, instead of being shaming and blaming, really supportive of those moms. So this is the peers in the neonatal unit. You can see we have CARES as kind of the curriculum we use for our certified peer specialist. I'm not going to read all this for the sake of time, but you can read a little bit about what they do specifically. But it's a really, really great program. Next, I have some information about resources that I want to make sure you take away with you. So we have the 988 line that launched recently, and then we also have a Georgia Crisis and Access line. And these slides detail the differences between these lines so that when you are getting people that you might need to refer, you can kind of figure out what might be the best line to use. So 988 is this 3-digit number that really is about suicide prevention with mental health crisis resources. They also can help people who are having issues with substance use disorder, but it is really a crisis line, and a lot of suicide prevention work has gone into that. So seeking emotional distress, mental health crisis, assistance with substance use, thoughts of suicide or self-harm. And then here are kind of the differences. The Georgia Crisis and Access line is 24-365. It's the direct line versus 988 might be routed to a call center outside of Georgia. It also guarantees the recommended for treatment, and it does some assessments here. So crisis line might be a better fit in some instances, but if you're dealing with anybody who is really unsafe from suicide or suicide risk, 988 might be the right line. As these are mobile crisis is something that we provide. Mobile crisis is a team that goes out when people are in crisis. It has licensed clinical social workers as well as a team of individuals to intervene and provide an intervention on site. So that's something to look at. And I won't, again, read all of these slides in the sake of time. This is more about the differences between 988 and GCAL as you assess what you might need. And then this is a little bit more about, this is a resource page here. So if you look at 988georgia.org, we have some videos, we have logos and branding, downloads and handouts if you want to get that to anybody that's in your waiting rooms or people you work with that you want to get that to them. And then I have a video here. I don't know if we have time for that. Probably not, but we'll send this out and you can probably click on it. But it's just a video promoting the 988 line. And then lastly, we have regional resources for behavioral health. So we have 6 regions in Georgia is how we're broken out at DBHTD. And we have regional service administrators in each of those regions. And so these are a list of each region, where it's located, and then who's the service administrator, and who you could contact for assistance if you have someone that you need to refer, or you need some assistance in the system, or you're having some challenges. These folks are on the ground in each of our regions. It can do a really great job of connecting folks to services and resources. And so I hope that I have provided you a 30-minute timeline. And then I also hope that I've provided you with some helpful information as you work in being in action, health in action, which includes behavioral health, includes physical health, includes a lot. And so I hope that this has been helpful for you, and I hope that the Department of Behavioral Health and Developmental Disabilities is a resource that you keep in mind as you deal with patients, for those of you who may not be practicing yet in the future, and those that are practicing, that you keep us in mind as a resource in our provider network. Thanks again for having me. Have a wonderful summit and enjoy the rest of your week. Thank you so much.